Good afternoon. Thanks very much for joining us. Welcome
Keep
to
you waiting, Meg. Thank you. Thank you
no
for
Thank
this time together.
It's wonderful to have you with us. And I just want to, yes, and so the participants are joining us. So I just want to welcome everybody. We are going to get started now. So my name is Meg Davis. I'm based at the Graduate Institute in Geneva, the Global Health Center. And it's a great honor and pleasure to welcome one of my heroes, Winnie Byanyima, who's Executive Director of UNAIDS. And just by way of background, for those who haven't met Winnie before, she was previously the Executive Director of Oxfam International, which works in more than 90 countries worldwide. And before that, was elected for 3 terms to the Parliament of Uganda, led the first Women's Caucus in Parliament, led the establishment of the African Union Commission's Directorate of Gender and Development, and has numerous leadership roles that she's led in economic development and gender, including co-chairing the World Economic Forum. And maybe less well known is that she also has a background as an aeronautics engineer and worked for some time as a flight engineer earlier in her career. So, but some people may have first met Ms. Byanyima through this viral video, which we're going to share with you, just an excerpt from a panel discussion, The Cost of Inequality, at the World Economic Forum in 2019. So let's just have a quick glimpse of that video. I actually don't think we're hearing the sound. Sorry, we did test it and it worked great, of course, before we were actually airing. We would give it another try.
This is my first time at Davos, and I find it quite a bewildering experience, to be honest. I mean, 1,500 private jets have flown in here to hear Sir David Attenborough speak about, how we're wrecking the planet. And I mean, I hear people talk in the language of participation and justice and equality and transparency. But then, I mean, almost no one raises the real issue of tax avoidance, right? And of the rich just not paying their fair share. I mean, it feels like I'm at a firefighters conference and no one's allowed to speak about water. I mean, this is not rocket science. I mean, we can talk for a very long time about all these stupid philanthropy schemes. We can invite Bono once more, but come on, we gotta be talking about taxes. Yeah, exactly. That's it, taxes, taxes, taxes. All the rest is bullshit, in my opinion.
I actually came because I do believe we have an issue here. But I have to say, honestly, this is a very one-sided panel. Frankly, what people really want is the dignity of a job. I'd like for the panel to talk about beyond taxes, which every one of you have talked about. The only thing you've talked about in this whole panel on inequality, what can we really do to help solve inequality over time beyond taxes?
Let me tell you something. We're talking about jobs, but the quality of those jobs with poultry workers in the richest country in the world, the United States. Dolores, one woman we work with there, told us that she and her co-workers have to wear diapers to work because they are not allowed toilet breaks. This is in the richest country in the world. So don't tell me about low levels of unemployment. You are counting the wrong things. You're not counting dignity of people. You're counting exploited people.
I want to... It's really great. So I just was wondering, first of all, this video went viral, had millions of views, kind of viewership we can only dream of here at the Global Health Center. So I hope you'll help us to go viral again today. We'll do our best. But I'm just curious, I mean, this took place in 2019, so it was before the COVID pandemic. And my first question is, were you surprised to see the kinds of inequality that COVID revealed to us? Or was it more or less what you would have expected in 2019?
Well, thank you, Meg. I do admire the work that you do, and I'm delighted to be here with you. No, it's not a surprise. At that time, when that video was captured, I had mentioned that billionaire wealth was rising 6 times faster than the salaries, the wages of ordinary workers, 6 times faster. The world was creating 2 billionaires every 2 days, 2 billionaires every 2 days. But ordinary people were sinking as people at the top. And now what we're seeing is probably worse than what it was before COVID. Let me give you one stat. The world's workers have lost $3.7 trillion in lost earnings since COVID hit. $3.7 trillion lost to ordinary workers. That's ILO data. Now, the world's billionaires have gained $3.9 trillion in increased wealth since COVID hit. You see the two directions. Billionaires are reaping from COVID, ordinary people are sinking. So I imagine that inequality is rising even faster now under COVID. And of course, it's not just about income inequality, it's also really a health crisis. 107 million people have been infected, 2.3 million have died, and more are dying. And why? Why this inequality? Because the economy is rigged, because there are rules that play for the rich and that hurt ordinary people, and governments are not seizing the opportunity of a crisis to level out the economy. They are not unrigging a rigged economy. If you talk about workers having dignity at work is the hallmark of a civilized society. But giving workers good jobs, good jobs don't come from thin air. It is policy choices that governments make, and governments are not choosing to make the right choices even now in the crisis. Talking about the rules that are hurting us in this crisis, we have a global problem. We need a global solution. COVID is hitting every country in the world. But today, 3 companies, American and European, are holding on to their know-how, onto their technology under intellectual property rules, and people are dying. We've calculated that the 3 biggest vaccine companies in the world are currently planning to produce vaccines for just 1.5% of the global population this year. 1.5%, that's all. Meanwhile, so far, 128 million doses have been administered. Almost all of them to 10 rich countries. 130 other countries have received not a single dose. See that inequality. But all because we have some intellectual property rules that some governments seem to think that they are God ordained, that these rules cannot change. These rules were made only a few years ago, Meg, 20, 30 years ago, under WTO, maybe not even 30 years. They can change. South Africa and India have proposed at the WTO TRIPS Council that these rules be suspended in this situation of crisis so that we can maximize production. Because the solution is to maximize. This scarcity is artificial. It's these companies holding on to their intellectual property. The governments which put money behind these companies to get the vaccine are letting them get away with it. They could use their political leverage to make them share the technology to maximize production. I'll come to how that could be solved. But the fact is that politicians, instead of looking for a way to catch up with the virus is mutating. And through its mutation, it becomes harder and harder to fight. Even these 3 vaccines, in a couple of months, could become useless. So we need to move fast and vaccinate everybody. That requires maximizing production. Sharing the technology can happen through a WHO pool that was set up for this. Secretary General has been calling and calling. Some developing countries have come together and also calling, but the rich countries say no. They prefer that this vaccine is produced by a few companies, they trickle in. Now the rich countries are themselves quarreling between themselves because the supply is too slow, too little. No, we can do better. This is not about some getting and others not getting. This is not about profits. It's about super profits. The vaccine producers can put their technology in the CETA pool, COVID technology access pool. They can license under certain conditions other producers so that we achieve maximum production and a quick pace towards catching up with the virus. But it is all about the rules. The rules don't work for ordinary people.
Well, I'm glad that you raised the rules. So maybe we could delve into that a little bit more, and maybe coming back to HIV. Though I think we all really appreciate the work you've done is really spearheading the call for equity and access to the vaccines. But how are you seeing income inequality play out for people who are vulnerable to HIV? And what are some of the rules there that you think are undermining progress?
Of course, these same rules have undermined the lives and the health of people living with HIV. We must not forget that in the 90s, when antiretrovirals were first discovered in America and in Europe, again, the price was too high. And for the next 6 years, while people in rich countries could get the medication and live long, healthy, productive lives, 9 million people in developing countries died because they couldn't afford. It took, again, some middle-income countries to protest and to insist, and that then generics were produced and the price came down. We don't have to wait for that. So that's one way. The same rules still work against ordinary people. And even for other diseases, you still have countries that are outpriced, are not in the game because of that. Look at what's happening now with the COVID pricing again. It's so opaque and untransparent. These companies can get away with opaqueness and can charge different prices. The Oxford AstraZeneca vaccine, South Africa is going to pay $5 per dose. My country, Uganda, which is poorer than South Africa, is going to pay $7 per dose. And here in Europe, it costs $2 per dose. So the rich pay less, the poor pay more. Because the companies can get away with it. That's why they do it. This happens also in other areas of medicines for poor people. Either they are not researched because they don't create a market for a super profit, so there's no treatment, or if it is there, it's out of reach. And that's only one way that the rules don't work. There is an even more sinister way where the rules work against the health of ordinary people. I know women who work in the global supply chains of big business, who stitch the clothes we wear, who cut the chickens that are put on the women I was talking to in America, in Arkansas, cutting chickens that we eat. The conditions of work of these women and men are so unhealthy. Women in Arkansas told us that they had repetitive strain injury and couldn't hold their babies because of cutting chickens, so many chickens at a fast pace. Women in Bangladesh get fired when they get pregnant, do not get paid when they fall sick, and get a miserable pay that keeps them trapped in poverty. These are unhealthy conditions. You would say that perhaps they can go to a public health service and get treated when they're not well. No, the public health services are collapsing. Why? Because the same rich companies don't pay their fair share of taxes, so there's not enough revenue to give everybody free healthcare. So you see that ordinary people pay twice.
Right.
First, their health is undermined as workers. They have no voice. Second, they have no public services because the rich don't pay their taxes.
Right.
Rules again, rules.
Absolutely. And it's so refreshing to hear you talk about these income inequality issues in the HIV response, because, and I think speaking also as someone who's worked on human rights as part of the HIV response, we haven't talked enough about this. I think we've talked a lot about the issues around criminalization of transmission of HIV, criminalization of key populations, property, intellectual property regulations. All of these are critical issues for the HIV response. But these issues around tax justice and labor rights are equally critical and are really shaping the financing, the available financing. And I'm thinking now of another example, which is anthropologist Nora Kenworthy, who worked in Lesotho, revealed some of the abusive labor practices in factories that are manufacturing product red products that are sold to benefit the Global Fund and other HIV programs. But because the women in these factories were not able to mobilize to advocate for their rights and for fair pay, many wound up engaging in transactional sex to supplement their incomes. And I'm sure this is common in lots of other places, right? It's this intersection of gender, labor rights, and then, as you say, lack of financing available.
You've touched it. It is how different axes of inequality combine to crush those who are at the intersections. Women, poverty, men, particularly young men who are gay and poor, always find themselves, they are the ones without jobs. If they are found, if they are known, they will not get a job. And if they get a job, they'll be so underpaid, the conditions will be so hard, and then they are discriminated in public services. But you touched on the issue of financing. You know, for many of the low-income countries, particularly in Africa, the HIV response is still largely dependent on aid. The government's own health services are collapsing. Even before COVID, many, more than half of the African countries, sub-Saharan African countries, 4 out of 5 were already paying more for debt repayment, in debt repayments, than their total health budgets. So there's so little there for health spending. Their HIV responses are funded externally up to 90-95%. And why? Because the people who suffer from HIV are right at the bottom. They are the least important. They are not prioritized. The bill is picked up by a kind government that gives aid. But this is not sustainable. And when you look at who are these people who come for these services, they are poor, they are discriminated, they are stigmatized, they are rejected in their society, and they are supported externally. It just tells you the huge inequality in rights. These are citizens. They should have equal rights. They should share what is available. But no, they don't even get a bit of what is available. But let's not forget that these governments have wealth. If they were taxing the companies, the digital companies that sell the ICTs and the Wi-Fi, if they were taxing the minerals appropriately, fairly, if they were taxing the natural resources, they would have the money to pay for this.
I was just looking at some of the statistics from the Tax Justice Network from their most recent report. They found that tax avoidance costs countries over $427 billion each year, and that they estimate that's one nurse's annual salary every second. Guess it depends on the nurse, but yes. Some of the biggest tax havens are here in Europe. So the UK, Netherlands, Luxembourg. High-income countries are responsible for 98% of all tax loss. So how do we begin to address this?
You see, when there was the global financial crisis, you've touched a really important point. When there was a global financial crisis, poor countries, developing countries had been for years complaining about the tax loss to them because of tax havens, because of a global tax system that is full of loopholes where they lose their income. They are not able to tax where the production is. There was silence. But when the global financial crisis hit and the whole world went into a recession, the rich countries now wanted to maximize revenue. They didn't have revenue. So they started to look at their companies and to tackle tax dodging. They came together under the OECD, the Club of Rich Countries, and started a big project called BEPS, Base Erosion and Profit Shifting, and put pressure on their companies and changed the rules, increased transparency between themselves, and forced these companies to pay up more. But they didn't include the developing countries in these discussions. They started by having them as observers. Well, some of us activists said, no, this isn't fair. Developing countries lose more than rich countries through tax dodging. They need also to have their issues on the table and addressed. It didn't happen, but after a lot of pressure, some countries now are part of these discussions in the second and the third round of these OECD discussions. Now, to cut the long story short, today, because of COVID, the whole world is going into a recession again, has gone into recession. Rich countries will be looking for how to meet their needs, how to tax more. There is still scope for taxing. Look at digital. Digital isn't paying their fair share of taxes. They collect, but digital collects money from all over the world. Their business is across borders. It doesn't respect the rules that we have in place. We have to have new rules to make digital and to make other industries pay. What we need is that there should be a global corporate tax reform, so all of us gain from more transparency and tighter rules to stop tax dodging by big companies. Developing countries will benefit more. Then we'll be able to pay for our health budgets. Then developing countries will be able to meet the right to health. Without that, and it's the rich countries who need to provide the leadership for a global negotiation, not a one-sided negotiation that helps them maximize while others still lose. So I'm hopeful, but I'm not seeing all the signs of wanting or having the drive and the leadership to change these global rules that are cheating ordinary people and only benefit a handful of owners of capital and technology.
Great, thank you. I want to encourage people to start posting their questions in the Q&A, which I actually can't see. So I'm going to ask my colleagues at the Global Health Center to repost them in the chat so that I can see them. So I just wanted to come back to this question of prioritization, which you raised, which I think is so important. And the reality is, of course, that many countries don't have enough funds to finance every aspect of the HIV response. In the past, UNAIDS has called on countries to really fund scaling up treatment in order to reduce new transmissions. But the cost of treatment is so high, of course, for all the reasons you've just outlined, that it means we've had much less investment in prevention. And that's especially true, as we know, in middle-income countries where donor countries are withdrawing their funding. So especially key populations, sex workers, men who have sex with men, trans people, people who use drugs, are not being prioritized in a lot of middle-income countries. And so we see this increase in new infections, especially among key populations. So I'm curious if you could say, given these difficult financial pressures, how should countries prioritize their funding?
Well, you're right that we have put more effort in the last 5-10 years on getting people living with HIV on treatment, testing and treating. And a lot of progress in many countries, high burden countries, has been in getting people onto treatment to live long and healthy lives. Great. But prevention has not received as much attention, and so we haven't been making as much progress to stop people from getting HIV. And this is sad because first, it means people get this virus and there's no cure and are going to live with it for the rest of their lives. But secondly, these countries keep increasing their recurrent cost of keeping people on lifelong treatment. And yet they want to reduce their dependence on foreign aid. So for those reasons, we have not made progress, and now we need to make faster progress, both on prevention and treatment. It's not either or, because also being on treatment, you don't infect. So treatment is also a way of prevention, because those who take the treatment and are virally suppressed do not transmit. But we need to tackle prevention for young people, especially for adolescent girls, young women, and young men. They need to be aware. We need to step up our effort in bringing them awareness to prevent them from getting the virus. Now, in terms of financing, certainly this is the time when we must stretch the dollar and make it. We can't afford to have a dollar that's not spent well. So that means better targeting, better data. And our data tells us that the real gaps, that actually it's inequalities that are driving this epidemic. That where there are gaps in rights, for example, where young men who are gay don't have their human right and their dignity and are not criminalized, they can't come for treatment. They can't come for prevention. So it's about closing these gaps. So we must put the money where the vulnerability is. If, say, my country, Uganda, if we find that this virus is increasing amongst LGBT communities, that is where our money must go. We can't afford to spend on a generalized epidemic as if we do not know that where the problem is here. I'm not saying that's where the problem, I've not looked at the data now, but I do know that across many countries, key populations, as you've said, because of the gap in rights, because of stigma, because of discrimination and criminal laws, they are not coming forward to get the benefit of the science. So we have to close that. And countries that refuse to recognize these people will continue to have an epidemic because it spreads across. Young people are spreading it heterosexually, gay men, sometimes bisexual. It still spreads. Sex workers have multiple partners. So unless everyone is given their right to health, the epidemic doesn't go away. So money is important, and money has now to be spent on your real epidemic, not the one a government wants to believe it has, but what the data tells us. And it has to be about closing inequalities between people. Am I talking too much?
No, it's wonderful stuff. And I see a lot of people cheering, including the Special Rapporteur on the Right to Health, cheering in the chat box. So that's great. I was just reminded as you were speaking about a statement that the Global Network of People Living with HIV and their former executive director, Rico Gustav, put out a couple of years ago, calling for us to put the last mile first, saying that we have to prioritize the people who are most likely to be left behind, because if universal health coverage works for those who are most marginalized, it'll work for the general population. Do you think that's reasonable?
It is so true. It is so, and that was really a clever way to put this, because we see, and that's why we framed our next strategy as closing inequalities, tackling inequalities to end the epidemic. If you have a delivery system that is accessible to those who are enjoying least rights, then it is accessible for all. But because we do not put the rights, the human rights of people at the center of our health strategies. So we never close that gap of rights, and it remains an obstacle. I'm thinking about young women, for example. You see, I was talking with Professor Mukwege, the Nobel laureate, who won it because of his work to tackle sexual violence in Congo. I was excited and I said to him, Professor, science has given us now a prophylaxis for women. So they will be able to take this tablet, and even if they are sexually abused, they won't get infection. Don't you think that's great? He looked at me and didn't look very excited. And he said, well, Winnie, I can't see that solving the problem here. Because young women don't sit there waiting to be raped. They're not going to swallow the tablet because they expect a rape. So it will only work if we are expecting a mass rape through, say, a rebel invasion. We might give it to a community, to women, and say, you know, in case there's an attack, please be sure you've taken a tablet. But for ordinary women and young women, they don't live their lives waiting to be violated. We have to tackle the social norms that make it acceptable to impose, to violate, to sexually violate a woman, a young woman. So in that respect, a health system that isn't also putting human rights at the center won't work for young girls and for women. We must have other interventions that make them safe so that they are prevented from getting infection. So this idea of having communities provide solutions for prevention and delivering treatment for themselves so that those who are part of the community can come forward and not fear is at the center of our strategy. It is the solution. You have to get human rights at the center. You have to put communities in the lead. I think if we can put those two there, we're going to make more progress.
That's great. And I'm so pleased you mentioned Dr. Mukwege, who, of course, won the Nobel Prize for his tremendous work creating kind of a one-stop shop, right, for survivors of sexual violence that includes medical care, psychosocial support, legal aid. So really linking women and girls to all the different kinds of services that they need and empowering them to be actors in their own behalf as well. So, yeah.
You got it. It's about linking, it's about integrated approaches. One of the great things that I learned about PEPFAR and the work they are doing was some pilots they've done in Southern Africa, where they're trying to address this issue of girls and adolescent girls and young women's higher vulnerability to HIV. In this region, girls are four times more vulnerable to infection than boys of the same age. To tackle that problem, they've been putting together several interventions and layering them, like keeping them in school, providing in school comprehensive sexuality education, income generation skills, because many of them don't go on to get degrees. They come out to learn, they learn a skill, and tackling toxic masculinities in school. They put a layer of interventions, sexual and reproductive health services. So by putting all this together, a girl's risk is reduced. No one thing can do it on its own.
Totally agree. And I feel like we could talk about this a lot longer, but we're getting pummeled with questions here. And I feel like I've been neglecting the audience for too long. So I just want to go to the first question, which came up for me anyway, which has to do with decolonizing global health. And you know, that's kind of a hip topic at the moment, probably long overdue. And so somebody has asked about the impact of colonial histories in shaping the kinds of inequalities that you're talking about. Do you see any link?
Yeah, there is a lot. There is a lot to deal with here. First of all, the approach to health itself is such a foreign concept. It undermines people's, it weakens people's health-seeking ways, or even their way of preventing illness to themselves. We are taught that you seek healthcare at a health facility. But the idea that actually you are your primary health carer and that it is all about you living a healthy life is not strong. And then there is the dissociation of physical health, mental health, and spiritual health. We come from communities where these things are seen together. If you are sick, you have made your ancestors unhappy. You must make peace with your family and your community in order to heal physically. This idea that's more holistic about health is missing in the colonial, the system of medical care that has come to us from our colonial past. So there is a need first to return to some more healthy notions about, more holistic notions of health, but which are, I think the best they call them is alternate. They are not alternate, they are mainstream. And people, you see, particularly in Africa, I'm sure also in Asia, you see people seeking health care from two systems. They go to the hospital, but at the same time, they want to consult a traditional healer because they don't see the whole together. There's a need for the systems to talk to each other, for people to get whole care. And then there is the superiority of modern medicine, that the doctor knows everything and you know nothing. And so you go to be told about your body, not to share what you know about your body, but more to be told. So the way healthcare is delivered is quite colonial. But apart from that, also the systems of delivery, the fact that communities are completely cut out. That's why we're in the crisis we are in, of an epidemic coming and hitting us, and we have to close our countries down, economies down, because our people themselves in their communities are not empowered enough to prevent, to fight an infectious disease. We are so proud that this is what we from the HIV movement have brought, that because this disease had no cure, no vaccine, everything depended on communities rising and sharing information, running campaigns for prevention, later on for testing and putting people on treatment. Communities became empowered to lead and protect their own health. This knowledge, where it has been tapped into, has helped those countries. Look at South Africa. We're so proud of them. In South Africa, it is the community health activists who fought HIV, who were first mobilized to go to do the contact tracing and to bring people forward for testing for COVID in the first phase. They are now being mobilized to work on the vaccination campaigns, the behavior change communications, the monitoring people. They will need to help people to come for a first jab, a second jab. This community mobilization, they just went and brought back the whole network of HIV. The scientists, it is the scientists, the HIV scientists who've been the epidemiologists, they are the advisors to the government on fighting COVID. The structure that worked for HIV is working for COVID, but this structure is the base, is communities. the basis communities, community health activists, community health workers, working with scientists and their labs and all that. So this is decolonization, where people take control of their own health, deliver services for themselves where they can, and take part in mass education on health and support each other. This is, I'm sorry, I don't have the evidence, but I really was living here, seeing COVID challenging rich countries. I could see that a system that is dependent on health professionals, a small group of health professionals in a highly technological health system, was so challenged to deal with COVID here. But back home, the challenges were huge, but they were of a different nature. They were of scarcity of this and that. But the systems for fighting infectious disease were there, and they were kicking in many countries of Africa.
Yeah, it's very interesting. And I think we could have another whole discussion about what countries that thought of themselves as developed could learn from African experience with COVID. But I think the point that you made just reminds me of how much talk there was in the response to Ebola about the importance of mobilizing communities and community engagement and talking with village leaders and so forth and local women. And all of those lessons just seem to have been forgotten when we're faced with COVID. But again, you know, it really is about that frontline kind of community engagement, people taking care of each other, finding out who's sick, the contact tracing, linkages to care. Those don't require an MD, right? I mean, a lot of those are just about having those community systems in place.
Absolutely. You know, I grew up in a village where I went through many of the diseases that all of us had. I had measles, I had chicken or smallpox, I had measles, malaria, mumps, all these diseases. They would come, and what they would do is that they would know that the whole village is all the kids are going to get mumps. So if you got mumps, your mom would put, there is a kind of red mud on your face and make you sit for an hour by the road so that everybody sees and knows that there's mumps in this house. Don't come.
No kidding.
That was the prevention method.
Talk about stigma and discrimination, though.
Well, but you see, you were a child. You were not actually being told that. People didn't laugh at you or shun you.
Okay.
Old people passed by you and greeted you, but it was a sign that we've got an infection at home. That's why someone's got a red cheeks. And it was meant as a signal to others that stay away, don't drop in to say hello. We have this. Of course, as a kid, you'd feel bad sitting by the road for an hour, but it wasn't a big price to pay to help the community contain a disease. I'm giving that example to show you that there is so much capacity in communities, so much inbuilt knowledge on how to prevent, but it is not triggered, it's not used. You are just told you're going to get a campaign brought by somebody or some professionals, but the capacity in communities is huge. And HIV unlocked it, the HIV movement unlocked it. We want to bring this into the global system so that there is better preparedness in the future. I think that this is how I understand decolonization. If we empower communities more, we will be prepared for the next pandemic. We must invest. This doesn't come just like nature. We must put some money into communities and preparedness. You know, there's got to be some way to oil this mobilization so that it's always there doing work when there is no pandemic, but when a pandemic kicks in, people know how to move into a preventive mode. It's
Mm.
not difficult, but it needs a resource and needs to be prioritized.
It needs to be funded, and groups have to be able to register and open bank accounts, which, as we know, in many countries is increasingly difficult, right, with growing restrictions on civil society.
Yes, we need to go back to base, because there was a time the HIV movement was well funded when the disease was ravaging communities more than today. But today it's rising again amongst young people, key populations, and there isn't any way of prevention unless we go back to what is tested, which is community prevention methods.
Well, as we move towards our last few minutes, I'm seeing a lot of questions about different kinds of economic reforms that would enable us to build back better in the future. One call for universal basic income. Suri Moon, who's our co-director at the Global Health Center, asked your views about IMF reforms and debt moratoria. I mean, if you would see certain priorities in terms of economic reforms at the global level in the future, zooming out from communities back to a global perspective, what would you see as the most critical things that we need to address?
We need some reform where I mentioned tax reform, corporate tax reform, to enable all countries to collect what is due to them, to tax what is produced in their countries or sold in their countries, so we can have the money to resource health, education, social protection, and so on. I would like to talk about labor reform. You see, we cannot, unless we have some global social contract, a new social contract, such that workers of the world can expect certain minimums from their governments and their corporations, we will not make headway, because one country will try to give a living wage to its workers, and the companies will get out through the back door and set up shop in another country. So unless we can have an agreement about the right to health, the right to unionize, the right to a living wage, these things are about human rights of ordinary people. We've reached a point where this shareholder capitalism just maximizes for shareholders, and all other people along the supply chain of a company don't matter. Workers don't matter, suppliers don't matter, farmers don't matter, the environment doesn't matter, communities don't matter. We have to get back to a multi-stakeholder capitalism where everybody matters, whether I'm a consumer or a worker or a community in the area where this is, we all count and we should get something from the business. So workers' rights are key there, and the fact that they were eroded since the 80s, that now workers are silenced, they live unhealthy lives, they live in debt, and they have constantly got to look for health. They are at risk of HIV, as you have said. I mean, look at sex workers. Sex workers in many countries are 20 times more at risk than other women. 20 times more in some cases. Why? They don't have to be. Just because they do sex work, they could do it safely. But they are criminals. They are not allowed. They are abused. So we need to have workers of every category having their rights, and their right to health is part of it. Another, the global financial system, the global financial architecture, that is so urgent today. I talked about the debt of low income, but also middle income countries like South Africa. Today, they can't lift themselves out of this COVID crisis unless the debt they have is suspended, and then they can borrow some money to buy the vaccines. What we are seeing now is a debt suspension initiative, the DSSI. It is too little, it's not deep enough. We need it to be for a longer time, up to say 2024. It needs to be legally binding. It needs also to come with new reforms to stop getting trapped in debt again. Because for every debt crisis, there is an irresponsible borrower and a reckless lender. It's two ways. And the rules allow this. Look at Mozambique. Mozambique was recently in debt distress. And it all came from a lot of loans that were borrowed without even the authority of their parliament. And later on, it was found that the lender, the financial institutions in Europe themselves broke their own financial rules and lent without doing all the due diligence. So you see that there is a financial system there that is cheating ordinary people because it, again, is all about some people making quick money, some few people. So we need some reforms in the global financial architecture. We need more rules. We need to change the rules, intellectual property rules. We cannot have profits coming before lives. Intellectual property rules in this area of health technologies have put the power of deciding who gets a medicine, when, at what price, in the hands of a few profit seekers. I don't even know why it's not so shocking anymore. It's shocking. So there's a need for a new multilateralism, a new rules that are pro people, not pro a few owners of capital.
I think that's a great agenda. And I guess as we just start to wrap up now, I wanted to give you a chance to address a question that came up a lot before you joined UNAIDS, and not so much since you've been in that role, which is about whether the world still needs a UNAIDS. Because of course, there's been criticism about the disproportionate amount of funding that goes to HIV relative to other diseases, whether it warps national health priorities. Is the time past for AIDS exceptionalism? So maybe I just wanted to give you a chance in your concluding remarks to reflect on why we still have UNAIDS.
It's a valid question to ask. My answer would be that we still need a UNAIDS for several reasons. One, we still have, last year alone, we had close to 800,000 deaths due to AIDS. You could say there are also other killers, that's true. We had millions of new infections. So we are still on the journey of controlling this disease. And it is a disease in poor countries. It's controlled in rich countries, but it's not controlled. We can control it. We just need to fight harder and reach the end. Not reaching the end means that it will surge again. That's the nature of epidemics. You don't finish it, it rises again. You postpone a problem and you compound it. So that's one reason. The other reason is that actually in fighting HIV, by wherever we make success, we also, like I said before, build a stronger people's system of managing health. Our investments in HIV are investments in prevention of other diseases as well, other epidemics that will come. It's an investment in community health, people being aware of their health and taking charge of their own health. So the work that we do is work that builds future preparedness. I would see this as something not to close, but something to use to build a more resilient, stronger health system of the future. So even if we controlled HIV, I would see that the work that we do is generic enough to contribute to future preparedness, maybe by being part of some other organization working on these issues. But certainly there is a need for the agency, for the joint program. That's also another reason that this is the first joint program of the United Nations where you bring together those who work on workers' rights, human rights, adolescents and sexual violence, gender equality, children, different angles to fight a health issue. I shouldn't even say a health issue, an epidemic, because the epidemic isn't just health, otherwise it would be done by WHO. But the UN found that it needed to bring various mandates together to tackle an epidemic. An epidemic is social, is economic, is legal, is human rights, is many things. So as an approach on fighting an epidemic, it's a successful approach. Even if we were to end, this would be an approach that I would want to see repeated in fighting future epidemics. So yeah, we are needed today to end this journey. We are working to reach the end of HIV as a public health threat. I see us declaring victory in 10 years' time. And that would be the moment to see where else we could contribute what we've learned over so many years.
Well, thank you. And on that note, I just wanted to note that your team was one of the first to issue analysis and thinking and guidance on how to address human rights in the COVID epidemic. And some of the other lessons have to do with the role of communities in global health governance, the importance of intellectual property regulation. All of these different areas, community mobilization that you spoke about, are not unique to HIV. So hopefully we'll have more opportunities to draw on your insights and on these lessons. But I see that we're out of time. So I thank you so much for your time. It's greatly appreciated.
Thank you so much. I've learned a lot from you, Meg.
Well, you're being very kind. But we didn't get to address all the questions, so we'll download them. We'll certainly share them with you and your team in case there are others you want to come back to on social media. But I just want to take this moment to thank the Global Health Center team who organized and supported this event, and to all of you who participated. We have 2 more events coming up next week. One which I'm actually involved in as well, which is about digital trust and why people are not downloading digital contact tracing apps. And a very exciting event to launch our guide to global health diplomacy with Dr. Tedros and many other luminaries. So thank you very much. And we hope to see you again soon. And stay safe.
Thank you, Meg.
Thank you. Bye-bye.
Bye-bye.